Now we'll start.
Complications of fractures. What is the first step in the treatment of this patient? Complications. General complication. Because of the trauma, there may be a damage of the possibility of injury to the abdomen, to the chest, to the head and neck, whatever. And local complication, which can be divided to early, urgent, less urgent, and late. Urgent complication, local visceral injury, vascular injury, nerve injury, compartment syndrome, Haemarthrosis infection, and as gangrene. Less urgent, like fracture, plaster sores, pressure sores, nerve entrapment, myositis ossificans, ligament injury, tendon injury, joint stiffness, and joint instability. Late complication like delayed mal or non-union, avascular necrosis, muscle contracture, ergodystrophy, and osteoarthritis. Visceral injury, the skeleton provide protection for the viscera of the body, like the brain, the lungs, the liver, the kidneys, urethra, bladder, whatever, and any damage to the skeleton might cause damage of the viscera. Nerve injury. Common signs for nerve injury are humeral fracture, especially the junction between the middle and lower third fracture, causing damage of the radial nerve and causing aristodrome, as we can see in the picture. Elbow may cause injury to the median and ulnar nerve. Knee may cause injury to the peroneal nerve, causing putidrome or posterior tibial nerve. The first step in the management of nerve injury is documentation. The doctor should examine the limb carefully and should document whether there is nerve injury or not. In closed injury, 90% in 4 months will heal without interference. Early exploration needed in or after manipulation of a fracture. So here comes the importance of documentation. If you have a patient with a closed injury and he had no nerve injury, there is no signs of nerve injury, and after doing manipulation, after doing reduction for that patient, and he got after reduction nerve injury, it indicates that this is an iatrogenic and it needs urgent exploration. While the patient who presented with closed fracture and nerve injury, we should wait for 4 months because the possibility of spontaneous recovery. Nerve compression. Nerve compression is a condition occurs especially around the wrist joint where the nerve is compressed, especially median and ulnar nerve, may cause paresthesia and other distribution of the median, and ulnar nerve. Vascular injury. The common sites for vascular injury are the knee joint, elbow, humeral shaft fracture, and femoral shaft fractures. The type of vascular injury, the artery may be cut, compressed by pieces of fracture, torn because of the unstable limb, contused, spasm, or intimal detachment. The effect of the vascular injury, either transient diminution of blood supply when like the condition when there is a spasm of the artery and then go back to normal, or complete ischemia. Clinical features, there is paresthesia, numbness, cold, pale, cyanose, extremity, pulse, weak, or absence. X-ray is important to check for the reduction, and angiogram, as you can see in X-ray, show the cut of the artery. Treatment. First step in the treatment, we have to remove the bandage and we have to re-X-ray to check for the reduction. If circulation does not improve within 30 minutes, we have to go for angiogram and we have to prepare the surgical theater for surgery, which include both dealing with the artery by suturing or grafting of the artery, and we have to reduce and fix the fracture. Compartment syndrome. Fracture of the arm or leg can give rise to severe ischemia even if there is no damage to the major vessel. Bleeding, edema, or infection may increase the pressure within one of the osteofacial compartments. There is reduced capillary flow, which results in muscle ischemia. Further edema, still greater pressure within the compartment, and more profound ischemia, a vicious cycle that develops. And after 12 hours or less, 4 to 6 hours, the necrosis of the nerve and muscle will occur within that compartment. Nerve is capable of regeneration, but muscle, once infarcted, can never recover and replaced by inelastic fibrous tissue, what we call Volkmann ischemic contracture. Similar cascade or even or may be developed in tight plaster casts. Clinical feature: high risk injury of fracture of elbow, forearm bones, proximal 1/3 of the tibia, multiple fracture of the hand or foot. Other precipitating factors are operation, usually for internal fixation or infection. Beware that compartment syndrome may be rise in a crush injury, circumferential burn, or even in a tight plaster cast. The classical features of ischemia are the 5 P's: pain, paresthesia, pallor, paralysis, and pulses. However, in a compartment syndrome, the ischemia occurs at the capillary level, so pulse may still be felt and the skin may not be pale. The earliest of the classic features are pain or a bursting sensation, altered sensibility, and paralysis, or more usually weakness in active muscle contraction. Skin sensation should be carefully and repeatedly checked. The ischemic muscle is highly sensitive to stretch, so when the toes or fingers are passively hyperextended, there is increased pain in the calf or forearm. Confirmation of the diagnosis can be made by measurement of intrafacial pressure, compartmental pressure by a special catheter inserted into the inside of the compartment, and by the equation that the differential pressure might be equal to differences between the general diastolic pressure and the compartment pressure. If less than 30 millimeter mercury, this is an indication of immediate compartment decompression. Treatment. The threatened compartment or compartments must be promptly decompressed. Cast, bandage, and dressing must completely removed. Only splitting the plaster is usually useless, and the limb should nurse flat. Elevation the limb causes further decrease in end capillary pressure and aggravate the muscle ischemia. The delta P should be carefully monitored. If it is found below 30 millimeter mercury, immediate open fasciotomy is performed. In the case of the leg fasciotomy, mean opening all 4 compartments. If facilities of measuring and the wound should be left open, and after 2 days should be inspected for closure. If facilities of measurement of compartment is not available, the decision of operation will be dependent on the clinical ground. If the 53 or more of the classic signs are present, the diagnosis is almost certain. If the signs are equivocal, the limb should be examined after 15 minutes interval, and if there is no improvement within 2 hours, splitting, dressing, fasciotomy should be performed. And as we have said before, the muscles will die within 4 to 6 hours, so we have no time. First step, you have to remove the bandage, you have to remove all the dressing, and you will wait for less than 2 hours by rechecking the patient every 15 minutes. If no response, we go for fasciotomy. Haemarthrosis means bleeding inside the joint. The patient have severe swollen, tense joint. The patient will not permit any movement of that joint because it's very painful. And the first step in the management is to drain that haemarthrosis from the joint before starting any further management. Infection. As we said before, there are two types of fractures, open fracture and the closed fracture, and the open fracture is potentially infected. Closed fracture, it is very, very hard to see infection in closed fracture unless it has been changed to open fracture by the surgeon in order to do internal management of open fracture have been mentioned in the previous lecture, and the treatment of internal fixation, if the internal fixation with infection, if the internal fixation still provides stability to the bone, we may wait for union to occur and provide the patient with antibiotic and debridement and drainage surgery until the fracture heals. If the internal fixation does not provide stability and there is infection, we may need to replace it with external fixation. Gangrene, this terrifying condition caused by Clostridium welchi, which is an aerobic microorganism that survive and multiply in the tissue with low oxygen tension. The prime site of infection is dirty wound with dead muscle that has not been well and adequately debrided. Toxin produced by the organism destroy the cell wall and rapidly lead to tissue necrosis and promoting the spread of the disease. Clinical feature appear within 24 hours of the injury. The patient complains of severe pain, swelling around the wound, and brownish discharge is seen. Gas formation is usually not very marked. There is little or no pyrexia, but the pulse rate is increased, and characteristic smell become evident, which has been once experienced. This is never been forgotten. Rapidly, the patient become toxic and lapse into coma and death. It is essential to distinguish between gas gangrene and characteristic of myonecrosis, characterized by myonecrosis, from anaerobic cellulitis, in which is superficial gas formation is abundant, but toxemia usually strive in order to prevent unnecessary amputation. Prevention: deep penetrating wounds and muscle tissue are dangerous and should be taken care properly by completely excising them and cleaning them. Treatment: the key to life-saving treatment is early diagnosis and general measures such as fluid replacement, intravenous antibiotics, and hyperbaric oxygen to limit the spread of organism. But the main step in the treatment is decompression of the wound, removal of all dead tissue. In advanced cases, amputation may be essential. Hyperbaric oxygen chamber. The oxygen is pushed inside this closed chamber with high pressure, about 3 times atmospheric pressure, and with 100% concentration. fracture blisters, plaster sores, bed sores, pressure sores, all of them are superficial necrosis of the skin with infection due to pressure either caused by the plaster or the bed and need treatment, debridement, cleaning, and sometimes flaps. Delayed union and non-union, these two late complications will be dealt with later on by Dr. Saad. So we will pass quickly. Malunion, when the fragments join in an unsatisfactory position, unacceptable angulation, rotation, or shortening, the fracture is said to be malunited. Causes either failure to reduce the fracture adequately or failure to hold the reduction while healing proceeds, or gradual collapse of comminuted or osteoporotic bone. Clinical feature, the deformity is usually obvious, but sometimes the true extent of malunion is apparent only on X-ray. Rotational deformity of the femur, tibia, humerus, or forearm may be missed unless the limb is compared with the other side. X-ray is essential to check for the position of the fracture while it is genetic. This is particularly important during the first 3 weeks when the situation may be changed without warning and when deformity may still to be easy corrected. At this stage, it is sometimes difficult to decide what constitutes malunion. Acceptable norms different from one side to another, and these are discussed under the individual fractures. Treatment. An adult fracture should be reduced as near as anatomical position as possible. A position of more than 10 to 15 degrees in the long bone or a noticeable rotation, deformity may need correction by remanipulation or by osteotomy and internal fixation. In children, angular deformity near the bone ends may often remodel with time. Rotational deformity will not. In the lower limb, shortening of more than 2 centimeters is seldom acceptable, and shoelace is enough. If it is more than the limb lengthening may be required. The cosmesis, patients sometimes want some cosmetic interference because he suffers from some of the psychological disturbance about his appearance of the lip. Angular deformity, little is known of the long-term effect of a small angular deformity of the joint function. However, it seems to be likely that the malalignment more than 15 degrees in any plane may cause asymmetrical loading of the joint above and below and late development of secondary osteoarthritis. This applies particularly to the large weight-bearing joint. Avascular necrosis is another complication, and we have a full lecture discussing the avascular necrosis. Growth disturbance, joint instability. Joint instability, this is will be discussed in each joint separately. Osteoarthritis, we have a special lecture about osteoarthritis. Late soft tissue complications. Joint stiffness. Joint stiffness is a very disabling problem. Occurs especially in the shoulder, elbow, knee, but the most disabling one occurs in the small joints of the hand. Why it occurs? Occurs because of the Haemarthrosis and causing adhesion of the synovial membrane and also because of the formation of edema, which make adhesion to the surrounding structures like the tendon, the ligaments, and because of faulty position when we put the joint in the shortest, we put the joint so that the ligaments are in the shortest, and this will cause adhesion. When adhesion occurs, those will not return back to normal length, and fracture and stiffness will occur. So it's much better to put the hand in position of safe immobilization, as the picture seen below. The wrist slightly extended and the metacarpopharyngeal joint flexed to 70 degrees, the proximal distal interpharyngeal joint extended, and the thumb in abduction position. Heterotopic ossification, you see the X-ray of the elbow and the arrow pointing to a bridge of bone formed in the muscle. This is a complication that's occurred very common previously because of using of passive, forced, aggressive, passive exercise. Sorry. The patient, usually young adult, and he starts to have pain around the elbow joint. With the time there will be a swelling, and initially X-ray is normal, but CT show there is an activity or overactivity, and with the time there will be a formation of the bone bridge inside the bone, inside the muscle, that will cause adhesion and causing obstruction of the movement completely. Treatment, excising this piece of bone and giving the patient endometacin and some type radiation to suppress the process of bone formation inside the muscle. Muscle contracture, we will deal with it when we discuss the complication of the upper limb, especially the Boltzmann contracture that occurs due to entrapment of vascularity in the upper limb, when there's difficulty in extending the finger and the finger are kept in a flexion position. Releasing of the muscle is one of the surgical options. Tendon rupture, the existence of pulsus longus might rupture due to the damage of, due to the fracture of distal radius, called a fracture. We will deal with the tendon rupture, nerve compression, and nerve entrapment according to each condition later on. Complex regional pain syndrome, previously called pseudox dystrophy, and reflex sympathetic dystrophy orgodystrophy. And because the exact pathology is not known, now we use the term complex regional pain syndrome. The condition is much more common than was previously recognized, and it may occur even after relatively trivial injury. The patient complains of continuous pain, often described as a burning in character. At first, there is a local swelling, redness, and warmth, as well as tenderness and moderate stiffness of the joints near the site of the injury. As the weeks go by, the skin becomes pale and atrophic. Movements are increasingly restricted, and the patient may develop fixed deformity. X-ray characteristically show patchy rarefaction of the bone and osteoporosis. Treatment: the earlier the condition is recognized and treatment began, the better the prognosis. Elevation and active exercises are important after all injuries, but in this condition they are essential. And during the early stages, anti-inflammatory drugs and amitriptyline are helpful. Sympathetic block or sympathetic drug have been advocated for this condition. They do sometimes appear to help, but their effect is unpredictable. Prolonged and dedicated physiotherapy will usually be needed.
Thank you very much.
Thank you.
خلي نلخص هذه المحاضرة. احنا عندنا complications of the fractures. وين نركز؟ احنا كمقيمين دوريين ان شاء الله نتخرج بعد سنة، راح نركز على ال urgent complications، لانه هذه انت اللي راح تكون مسؤول عنها. ال urgent complications. الباقي complication شنو المطلوب من عندي؟ مطلوب من عندي انا اعرف التعريف، مثلا شنو يعني malunion، واخذ فكره عن الموضوع، لكن التركيز الاساسي لازم يكون وين؟ على ال urgent complications. باقي لنا محاضره واحده قصيره جدا ان شاء الله. هسه الساعه بال 11 الا 5، ان شاء الله ب 11 نبدي ناخذ المحاضره الاخيره. شكرا. شكرا. المطلوب من عندنا يوم الباكر شنو المطلوب؟ اثناء ما انطينا المحاضرات هسه اكو كويزين ذكرا داخل المحاضرات، هذول مطلوب من عندنا نجاوبهم وندز الحلول مالتهم اليوم ان شاء الله حتى باكر نشوفهم. هاي واحد. اثنين، مطلوب من عندنا ان ندرس اليوم الاناتومي، كلش ضروري هوايه anatomy of the upper limb. ليش؟ لان باكر احنا راح ناخذ التروما of the upper limb، فضروري ان اليوم نراجع anatomy of the upper limb، بالاخص كنا العظام واسمائها واسماء الاجزاء مالت العظام. باكر ان شاء الله ايضا موعدنا ب8 حتى نستغل انه النت شويه قوي ازدحام. والآن عندنا المحاضرة الأخيرة جدا، هي تتكلم عن fracture of epiphysis in children. احنا الأطفال عندنا بيهم خاصية بالنسبة للعظام مالتهم، أن عندهم الابيفيسيس اللي هو cartilage area، من عندها يصير replication of cartilage والgrowth of the bone. هذه منطقة الكارتج يصير بها fracture easily، حتى فاكو سبيشال فراكتشرز بالاطفال يسموها epiphyseal fracture من خلال الابيفيسيس. هذه لها سبيشال كلاسيفيكيشن يسموه سولتر هاوس كلاسيفيكيشن، راح نناقشها الان. هذا
fracture in children. Fractures in global bones are subjected to influences which do not apply to adult bones. In very young children, the bone ends are largely cartilaginous and therefore do not show up in X-ray images. Fractures of this size are therefore difficult to diagnose. So, always an X-ray for both limbs for comparison and an ultrasound scan may be helpful. Children's bones are less brittle and more liable to plastic deformation than those of adults. Hence, the frequency of cortical buckling and green stick fracture. In childhood, the periosteum is thicker than in adult bones. This may explain why fracture displacement is more controlled. Cellular activity is also more marked, which is why children's fractures heal so much more rapidly than those of adults. The younger the child, the quicker the rate of union. Femoral shaft fracture in infant will heal within 3 weeks, and in younger children in 4 to 6 weeks, compared to 14 weeks or longer in adults. Non-union is very unusual in children's fracture. Bone growth involves considerable modeling and remodeling processes, which determine both structure and form. This makes for a great capacity to reshape fracture deformities, other than rotational deformities over time. Injuries of the physis have no equivalent in adult. Damage to the growth plate can have serious consequences, however, rapidly and securely the fracture might heal. Injuries of the physis. Over 10% of childhood fractures involve injury to the growth plate of physis, because this is a relatively weak part of the bone. Injuries that causes ligament strain in adults are liable to disrupt the physis in children. The fracture usually runs transversely through the hypertrophic calcified layer of growth plate. Salter and Harris classification. The most widely used classification of the physical injury is that of Salter and Harris, which distinguishes 5 basic types of injury. Type 1, a transverse fracture through the hypertrophic or calcified zone of the plate. Even if the fracture is quite alarmingly displaced, the growing zone of the physis is usually not injured, and the growth disturbance is uncommon. Type 2. This is similar to type 1, but toward the edge, the fracture deviates away from the physis and split off a triangular piece of metaphyseal bone. Growth is not affected. Type 3. This fracture runs partly along the physis and then wears off through all layers of the physis and the epiphysis into the joint. Inevitably, the reproductive zone of the physis is damaged, and this may result in growth disturbance. Type 4. As with type 3, this fracture supplies the epiphysis, but it continues through the physis into the metaphysis. The fracture is particularly liable to displacement and a consequent misfit between the separated parts of the physis, resulting in asymmetrical growth. Type 5, a longitudinal compression injury of the physis. There is no visible fracture, but the lower plate is crushed, and this may result in growth arrest. Clinical features. Deformity is usually minimal, but an injury in a child following by pain and tenderness near the joint should arouse suspicion, and X-ray examination is essential. X-ray, the physis itself is radiolucent, and the epiphysis may be incompletely ossified. This makes it hard to tell whether the bone ends is damaged or deformed. The younger the child, the smaller the visible part of the epiphysis, and thus the more difficult. It is to make the diagnosis comparison with the normal side is a great help. Telltale features are widening of the physis gap, incongruity of the joint, or tilting of the epiphyseal axis. If there is marked displacement, the diagnosis is obvious. But even type 4 fracture may at first be so little displaced that there are hard to see is the faintest suspicion of a physical fracture. Second X-ray examination after 4 or 5 days is essential. Type 5 injuries are usually diagnosed only in retrospect. Treatment and displaced fractures. These may be treated by splitting the part in a cast or a closed-fitting plaster slab for 2 to 4 weeks, depending on the site of injury and the age of the child. However, with type 3 and 4 fracture, a check X-ray after 4 days and again at about 10 days is mandatory in order not to miss the displacement. Displaced fractures must be reduced as soon as possible. With type 1 and 2, this can usually be done closed. The part is then splinted securely for 3 to 6 weeks. Type 3 and 4 fractures demand perfect anatomical reduction. An attempt can be made to achieve this by gentle manipulation under general anesthesia. If this successfully, the limb is held for 4 to 8 weeks, the longer period for type 4 injuries. Here again, check X-ray at about 4 and 10 days are essential to ensure that the position has been retained. If a type 3 or 4 fracture cannot be reduced accurately by closed manipulation, immediate open reduction, and internal fixation with smooth K-wires is called for. The limb is then splinted for 4 to 6 weeks, but it takes that longer again before the child is ready to resume unrestricted activities. Complications. Premature fusion. Type 1 and 2 injuries, if properly reduced, usually have an excellent prognosis, and bone growth is not adversely affected. Exception to this rule are injuries involving the distal femoral and upper tibial physis. Both are undulating in shape, so a transverse fracture may pass through several zones in the physis and results in a focal point of fusion. Type 3 and 4 and 5 injuries are more likely to cause premature fusion or part of the growth plate, resulting in cessation of growth or asymmetrical growth and deformity of the bone ends. The size and position of the bony bridge across the physis can be assessed by CT or MRI. If it is relatively small, less than 1/3 the width of the physis, it can be excised and replaced by a fatter graft with some prospect of preventing or diminishing the growth stimulus. However, if the bone bridge is more extensive, the operation is contraindicated and the remaining part of the physis closed surgically. The resulting deformity or limb discrepancy will with later and or operative correction of limb length. Deformity. Established deformity, whether from asymmetrical growth or from malunion of a displaced fracture, like Valder's elbow due to proximal displacement or non-union of the lateral humeral condylar fracture, should be treated by corrective osteotomy. If further growth is abnormal, the osteotomy may have to be repeated. Spontaneous fracture in children. Fractures following minimal trauma may be due to unusual genetic disorder, osteogenesis imperfecta. It is obvious, however, that infant cannot say what happened to them, and one should keep in mind the possibility that they may be a victim of deliberate injury, the battered baby syndrome. Suspicious features are an unconvincing history, multiple fractures in different stages of healing, and bruises elsewhere on the body. X-ray may show florid callus formation mimicking the appearances of osteomyelitis or scurvy.
Thank you very much. حقيقة أكو بس نقطتين بالنسبة للمحاضرة. Bony fusion of the epiphysis in fracture 3 and 4 ذكرنا انه sometimes we excise the bone bridge and we put fat graft. الحقيقة هذه ما حد يسويها. العادة اللي نسويه هو corrective osteotomy. النقطة الثانية هي بالنسبة للباترن بيبي سيندروم، متلازمة الطفل المعنف. هذه حالة الأب أو الأقارب أو الأم يقومون بالاعتداء على الطفل ويسببوا له عدة كسور بالجسم. الحالة هذه عندنا رير، لكن بالغرب جدا شائعة، بالأخص بأمريكا استراليا بالمناطق. فخلوها ببالكم لما تشوفون طفل عنده multiple fractures، إذا ما كان عنده الكرايتيريا of osteogenesis imperfecta اللي راح نناقشها بالمستقبل. أكو أحد عنده استفسار، سؤال، شيء؟ خلي يفتح المايك ويسولف لنا. أوكي. المطلوب من عندنا بكرة إن شاء الله نرتب أمورنا، نقرأ اليوم الأناتومي مال الأبر ليم، نقرأ ذني المحاضرات، وإن شاء الله بكرة ناخذ التروما أوف ذا أبر ليم، والأمور راح تسهل بعد كل محاضرة. راح نعيد المصطلحات، راح نعيد الشغلات المهمة، فالأمور تسهل بالتدريج إن شاء الله. أشكركم على حضوركم، وإحنا حاضرين لأي مساعدة. شكرا.